We have another great issue this month, going over some critically important articles, beginning with an article from the New England Journal of Medicine titled Finerenone with Empagliflozin in chronic kidney disease and type 2 diabetes. And this is really an important article looking at the two in combination, and then followed by a discussion of another article from the New England Journal, Gross Diet, Efficacy and Safety in Patients with Uncontrolled Hypertension, a new class of antihypertensives. Then, I think one of John and my favorite programs out there, the Diabetes Prevention Program, and its outcome study, an overview of years and years of public health impact. Then, discussing an article from Diabetology on comparative effectiveness of alternative second-line oral glucose-lowering therapies for type 2 diabetes. And we are going to end on a critically important article about a critically important topic, metabolic-associated steatohepatitis and a phase 3 trial of semaglutide. John, you want to dive in first?
Neil, let's get rocking. So our first article is from the New England Journal of Medicine, looking at Finerenone with empagliflozin and chronic kidney disease in type 2 diabetes. So the researchers randomly assigned participants who had chronic kidney disease, who had a GFR somewhere between 30 to 90 mLs per minute, albuminuria with albumin to creatinine ratio somewhere between 100 to 5,000, in type 2 diabetes in patients who were already receiving a renin-angiotensin system inhibitor. In a 1-to-1-to-1 ratio, they were going to receive either Finerenone, they were going to receive empagliflozin, or a combination of the two. The primary outcome was the relative change in the mean urinary albumin to creatinine ratio from baseline to 180 days. They also followed safety metrics. At baseline, the urine albumin to creatinine ratio was similar among the participants in the three groups, with a median value of 579. Among those with available data, there were 250, 260 in each group. At day 180, the reduction in the urine albumin to creatinine ratio with combination therapy was 29% greater than with Finerenone alone and 32% greater than with empagliflozin alone. Neither agent alone or in combination led to unexpected adverse events. Symptomatic hypotension, acute kidney injury, and hyperkalemia leading to drug discontinuation were uncommon. Neil?
John, this is an important article. Remember, we went over the original Finerenone trial, the Fidelity trial that was published in the New England Journal in 2020. That trial had over 2,800 patients, lasted about 2.5 years, and the primary outcome of kidney failure, a sustained decrease of at least 40% in eGFR from baseline, or death from renal causes, was markedly positive with a very significant p-value, showing an 18% decrease in that primary outcome. Then, about a year later, we also went over on this podcast the Figaro trial, New England Journal, 2021, over 7,000 patients, 3.5 years. And here, they looked at a critically important endpoint that we often forget with this class of medicines, as well as forget with the SGLT2s, and that was a composite of death from cardiovascular causes, non-fatal MI, non-fatal stroke, or hospitalization for heart failure, and it showed a statistically significant 13% decrease. Really important, very comes. But the question that has been nagging most of us clinicians out there practicing has been, how does it do on top of not just ACEs and ARBs, which it was studied on top of, but on top of SGLT2s, which only a relatively small percentage of people in those two trials had. John, the article you just went over answers that. So on top of, actually not on top of, started concomitant with empagliflozin, we see this substantial decrease in UACR, showing that the two work synergistically together, which is what we'd expect. They work through different mechanisms. And this is important because it tells us two things. One, in someone with significant chronic kidney disease who we are considering both medicines, we can safely start them together, and by doing so have a greater effect than starting either one alone. And two, that we don't then risk therapeutic inertia by starting the SGLT2 and saying we'll get to finerenone maybe if needed at some point. So this article adds substantially to the literature showing that finerenone and empagliflozin, when started together in people with significant chronic kidney disease, do better on both than on either one alone. Our next article is a fascinating one, John, because it addresses resistant hypertension, which we see a lot of. And this was in the New England Journal of Medicine, the Advanced Hypertension Trial of lorundrostat, efficacy and safety in patients with uncontrolled hypertension. Lorundrostat is an aldosterone synthase inhibitor. We know that aldosterone dysregulation contributes to hypertension, and this is one of a few aldosterone synthase inhibitors that are in development. This was a multi-center, double-blind, randomized, placebo-controlled trial. Participants were receiving 2 to 5 antihypertensive medications and had a blood pressure measurement still of 140/90 or higher obtained during an office visit. They then were put on a standardized antihypertensive regimen for 3 weeks. Subsequently, participants with an average 24-hour ambulatory blood pressure of 130/80 or higher were assigned to receive placebo, lorundrostat at a stable dose of 50 milligrams daily, or lorundrostat at a starting dose of 50 daily with an increase to 100 daily if systolic blood pressure was 130 or higher after 4 weeks. The primary endpoint was the change in 24-hour average systolic blood pressure readings from baseline to week 12. There were 285 participants. Mean age was 60 years. After 12 weeks, the mean change in 24-hour average systolic blood pressure was a decrease of 15.4 millimeters of mercury in the stable dose group, a decrease of 13.9 millimeters of mercury in the dose adjustment group, and a decrease of 7.4 millimeters of mercury in the placebo group. A potassium level above 6 occurred in 5 participants, which was 5% in the stable dose group, 7% in the dose adjustment group, and none in the placebo group. John, your thoughts?
So, Neil, kind of lots of thoughts about this. Hypertension is certainly a bread and butter thing that we're doing in the office. And been loads and loads of blood pressure studies during our career, and probably as a nation, we have grown more aggressive about this over our careers. I remember as being a medical student, someone actually mentioning a systolic blood pressure could be 100 plus someone's age. We found that out pretty early after I had initials after my name. That really wasn't true, and we have watched it march down. And as we've looked at all of these blood pressure studies, I think one of the things that you and I have learned, and we have talked with young learners about, is if we're really going to get someone down in that 120, 130 range, we're going to need to have multiple medicines. And studies ranging, much like this study, somewhere in that 2.4 to 3.6, even to get down to 140/90 in a lot of these studies. So a lot of people are going to need multiple medicines. I think the other thing is over our career is we could treat people with multiple medicines for a pretty decent price point right now. So a lot of the big discount pharmacies, people can get most of the medicines that you and I are using in a generic form that's fairly inexpensive. So that said, we still have people that we can't get there. And, what's going to be the answer? And we've watched this particular medicine kind of march through there was a phase 2 clinical trial in the JAMA system last year. So it looks promising. So takeaway is it would be great to have kind of that ace in the hole to add for lowering patients' blood pressure. The questions I'm going to ask when this medicine eventually, if it does make it out onto the market, is where does this fit in? Where does it fit in compared to cheaper, older spironolactone? Should we just be using spironolactone more often in this kind of access is something that we have? I was interested in this paper that as you went up on the dose, you went up on some of the side effects, you really didn't go up on the efficacy. And I certainly think that's our experience with hydrochlorothiazide. If you look at one of the guides, it can say you can give up to 50 milligrams a day. Probably anyone in practice probably caps it out at 25 because, like in the study, you get more hyponatremia. You get, in that instance, you get more hypokalemia, you get more hyperkalemia here. So this could be an interesting add-on. And I also think coming away from this is this, hey, this is my ace in the hole. My ace in the hole is really only impacting systolic blood pressure by around 10, 11. So there are guidelines out there for someone whose blood pressure walks into our office and we check it a couple times, that's 20 points over our systolic goal, we probably should start 2 medicines. I'm not sure we always do that. And that's also a great place for combination medicines because the patient only thinks they're taking 1 medicine. So how we take care of blood pressure, as we've seen in ACCORD trials, that blood pressure control in our patients with diabetes can be just as important as blood sugar control if we're looking at some of the cardiovascular endpoints. So for our next article, we got a big meal ahead of us, so we're gonna kind of share the cooking here, and we're looking at the Diabetes Prevention Program, its outcome studies, a journey into the prevention of type 2 diabetes and its public health impact. Neil, you want to start us off?
Sure, John. This is probably one of my favorite series of articles of all time, going back to the New England Journal in 2002 and the publication of the Diabetes Prevention Program trial. We'll get to that in a little bit. And it's important because we know a lot of people in the country have diabetes. We often forget that there are almost 100 million people with pre-diabetes, and there's a big imperative to slow progression or maybe stop progression for those people to progress forward to diabetes. And the Diabetes Prevention Program was a multi-center randomized clinical trial program that was conceived of all the way back in the early and mid-1990s. And initially it included lifestyle versus metformin versus a TZD versus usual care, which while in usual care we say you ought to do some lifestyle modification, there's not a lot of emphasis put on it. Here, the lifestyle group really got rigorous input, regular meetings with dietitians, with health coaches in order to facilitate them achieving those lifestyle changes. And then after the Diabetes Prevention Program ended, they did the Diabetes Prevention Program outcome study. So this article was written on the 75th anniversary of this program to give us an overview of it. You want to take it from here?
I love history, so going way back, Jocelyn in 1923, 102 years ago, said diabetes is largely a penalty of obesity, and the greater the obesity, the more likely is nature to enforce it. The sooner this is realized by physicians and the laity, the sooner will be advancing frequency of diabetes will be checked. So epidemiologic insights led to the recommendations 40 years ago that drugs, diet, or exercise in individuals with impaired glucose tolerance be investigated for type 2 diabetes, kind of starting us on our journey. So looking at our trial, so the DPP went on from 1995 to 2001, and that was the first trial designed to evaluate the efficacy and safety of not only a lifestyle intervention aimed at weight loss and increased physical activity, but also medicines to prevent or delay the development of diabetes. There were more than 158,000 individuals who were screened to be eligible. They had to be over 25 years of age, at high risk of developing diabetes. Eligibility criteria included being overweight or obese, a BMI greater than 24, elevated fasting glucose by the usual parameters that we use. The eligible participants, which turned out to be about 3,800 patients, were randomly assigned in the 96 to 99 period to either metformin 800 milligrams twice a day, a glitazone at 400 milligrams daily, double placebo, or intensive lifestyle intervention. All treatment groups were double masked except for the intensive lifestyle study. The primary outcome, diabetes development, was assessed semi-annually on the basis of a fasting plasma glucose or annually with an oral glucose tolerance test that followed the ADA criteria of fasting greater than 126 or with a 2-hour challenge greater than 200. After a median of 2.8 years of the study, the Independent Data Monitoring Board recommended in May 2001 that the trial stop 1 year ahead of schedule based on the demonstrated efficacy of both interventions. So compared with placebo, lifestyle intervention reduced body weight by about 4 kilos and diabetes development by 58%. Adherence to metformin was about 70%, and it reduced diabetes by 31%. So Neil, do you want to pick up our story?
Yeah, John, and that was a big deal because really it showed for the first time that intervention with effective lifestyle changes could make a big difference. And I remember when this came out, and I was just blown away that lifestyle is about twice as good as what at that time was the best medicine out there. So the lifestyle intervention worked. It led to reduced weight. People actually did exercise more. It improved estimated insulin sensitivity and secretion. Now, the reduction in the diabetes incidence in the group was largely, when they separated things out, interestingly, attributable to weight loss, with a 16% reduction in diabetes development per kilogram lost. Metformin was less effective than lifestyle intervention for people losing weight, and therefore it was useful in decreasing progression to diabetes compared to essentially no interventions, but it was not as good as lifestyle. The primary DPP results were consistent with other randomized trials of lifestyle intervention that are out there. Then, having that result, and that result, remember, was published in 2002 in the New England Journal, the value of diabetes prevention as a public health strategy wasn't just that it could be shown short-term in decreasing progression of diabetes over a few years, but also how would it do in terms of decreasing the complications of diabetes down the road. So this led to the long-term extension of the diabetes prevention program into the diabetes prevention program outcome study, which has been going on from 2002 all the way to the present, and along with the aging of that cohort, included in some of these outcome trials that are being looked at now are things that affect older adults, such as physical and frailty and cognitive function. John, do you want to go over some of those long-term effects?
So looking at the microvascular complications, in the patients who developed diabetes versus the patients who didn't develop diabetes, roughly across retinopathy, peripheral neuropathy, and nephropathy, in the most part, there was an odds ratio of about 1.4 of people developing these diabetes-related complications, and the people developed diabetes versus the people who didn't. So looking at some of the macrovascular differences, so during the 21 year of follow-up, there really was not a significant difference in the MACE criteria that we would look at, that we've looked at so many medicines over the last few years between the metformin and the lifestyle group. There really was not seen the big difference in cognition. There was some decrease in frailty seen in the people who developed diabetes. Again, that odds ratio about 1.46. There was no difference seen in cancer. Neil, do you want to wrap up talking about quality of life and really the importance of this study to what we do every day in our office?
Yeah, John, this was an incredibly important study where they had an immense amount of foresight back in the 1990s to recognize that this was an enormous public health problem. And the way that we address public health problems ought to be at their root causes. And so it used a systematic approach to look at diet and exercise to address what was a burgeoning epidemic. And it showed that approach to be successful and, as they go over in this article, cost effective. And from those studies, the diabetes prevention program was adopted by the CDC, was translated into many communities, done at YMCAs and other non-distinctly health facilities using lower cost models such as health coaches to carry out the program instead of dietitians. So incredibly cost effective, scalable. The question now as we move forward is, can this sort of program be in place earlier on? Because there are so many people with prediabetes, and we know that this continues to be a growing problem, the number of people with diabetes, the number of people with obesity, and can we institute programs? And let's even expand that further, societal changes that encourage healthy eating and increased physical activity as a way of promoting health, decreasing the incidence of diabetes, and by doing so, decreasing the incidence of complications. Our next article is from Diabetologia, and it is titled Comparative Effectiveness of Alternative Second-Line Oral Glucose-Lowering Therapies for Type 2 Diabetes, a Precision Medicine Approach to Routine Data. The aim of the study was to compare the effects on A1C of sulfonylureas, DPP-4s, and sodium glucose transporter inhibitors, SGLT2s, when they were added to metformin as second-line agents. They used a clinical practice research data link database in England to determine who got second-line treatment after metformin between 2015 and 2021. Looking, as I said, at the outcome was simple, straightforward, a change in A1C. The mean difference in A1C for SGLT2s versus sulfonylureas was larger for people 18 to 49 than it was for those aged 15 to 49, but in both cases, a little bit surprisingly, the SGLT2s had a greater about 0.3 to 0.5% decrease in A1C than the comparator sulfonylureas. The difference in change for SGLT2s versus DPP-4s was also in the same range. John?
So, Neil, I found this article very interesting. I really wish it had traveled back in time a little bit, though. I think when we look at the ADA's guidelines and we look at it 5 years ago, it was very much an equal opportunity. What's your next medicine after metformin? If we look at kind of the newer guidelines, we're actually prescribed to be in certain buckets based on kind of risk factors. And certainly a large percentage of our patients who have diabetes now are overweight or obese. We have a significant number of our patients with diabetes who have some heart disease or some heart failure or some kidney disease. So we really are not living in this very kind of generic world as what's next, because we're really giving much more prescribed kind of information. So that said, I found it to be interesting is overall, I really have been a big fan of the kind of the sulfonylureas just as a class with all the hypoglycemia. Don't use a whole lot of that, but I certainly recognize their kind of role price point wise. The DPP-4s never viewed that as a super strong medicine for lowering sugars. So I think as I am viewing the SGLT2s in many ways, as you and I might have viewed adenostat to someone with diabetes, that it does all these other things. This is encouraging that maybe it's going to provide a little bit extra kind of boost in lowering blood sugar than we might have anticipated in seeing just some of the standalone data from a lot of these products. So our last article is from the New England Journal of Medicine, a phase 3 trial of semaglutide in metabolic dysfunction-associated steatohepatitis. So this was an ongoing phase 3 multi-center randomized double-blind placebo-controlled trial in which the researchers assigned close to 1,200 patients with biopsy-defined MASH and fibrosis stage 2 or 3 in a 2-to-1 ratio to receive either once weekly subcutaneous semaglutide at a dose of 2.4 milligrams or placebo for 240 weeks. The results of the planned interim analysis conducted at week 72 involved the first 800 patients are reported here. The primary endpoint for part 1 were the resolution of steatohepatitis without worsening of liver fibrosis and a reduction in liver fibrosis without worsening of steatohepatitis. So the resolution of steatohepatitis without worsening fibrosis occurred in close to 63% of the 534 patients in the semaglutide group and about 34% of patients in the 266 patients in the placebo group. A reduction in liver fibrosis without worsening of steatohepatitis was reported in close to 37% of the patients in the semaglutide group and 22% of those in the placebo group. The results for the 3 secondary outcomes that were included in the plan to adjust for multiple testing were as followed. Combined resolution of steatohepatitis and reduction in liver fibrosis were reported in close to 33% of the patients in the semaglutide group and 16.1% in the placebo group, with an estimated difference of 16.5 percentage point. The mean change in body weight was a decrease in 10.5% with semaglutide and a decrease in 2% with placebo. Mean changes in bodily pain scores did not differ significantly between the group. GI adverse events were more common in the semaglutide group versus placebo. Neil?
John, I think this is such an exciting study. We know that MASH has become a lot more common and is on its way to being the most common cause of end-stage liver disease and liver transplant in the United States. Until recently, there were no FDA-approved medicines for this. Yes, we had some data that showed that vitamin E is helpful in people without diabetes. Pioglitazone, 2 studies showing that it is helpful in people with diabetes, but not rock-solid data. Recently, we had resmetirom approved by the FDA as treatment for people with advanced fibrosis and MASH. But that leaves a real gap. It leaves a real need for more treatments. And seeing this data on semaglutide, and last year we went over data in a phase 2 trial on tirzepatide, both of which showed important benefits in actually not just slowing progression, but reversing fibrosis in people with MASH is incredibly exciting. And what I find particularly exciting about this class of medicines with MASH is that when we think about it, for people with MASH, of course, progression to end-stage liver disease is a very important endpoint. But the other thing going on is all of the metabolic derangements, which have a bidirectional effect. The abnormalities in triglycerides, lipids, hypertension, the whole metabolic syndrome, making MASH worse, and MASH in turn making all of those things work. And the idea here of using a GLP-1, or from the phase 2 study, a dual agonist, in order to specifically reverse fibrosis, but also at the same time improve blood glucose, blood pressure, lipids, is particularly exciting because these are often people who are on a boatload of medicines. And you've talked many times on this podcast about twofers. If we're able to see this move forward, if the final trials end up being as promising as these early trials are and gain FDA approval for the treatment of MASH, this is a pretty mind-boggling, exciting twofer that gets metabolic problems, obesity, addresses diabetes, and reverses fibrosis from MASH. John, before we close, I want to share some important news with our listeners. As you know, in addition to diabetes, we've been covering the full range of cardiometabolic conditions, and so this summer, our name is going to be changing to meet that consistent mission. Starting this summer, 2025, our podcast will be rebranded as Diabetes obesity, and cardiometabolic update. I know. You're already thinking. And you're right. The new name is Doc Update. Diabetes, obesity, and cardiometabolic update. You'll notice this when the change is made on your subscriber feed. We'll have a new title and branding, same great information. For more information and links to the articles that we discussed in this issue, just go to diabetesjournal.org. Until next month, keep listening
and keep learning.